All right. Now it's not truly an exploratory because we know what we're going to get into. We know exactly what we're going to do. Now, the right word is more of a laparotomy. We're doing a laparotomy. That is true, right? We're making an incision into the abdominal cavity. So the instruments are going to be the same. Okay? We still got skin layer, subcutaneous. We still got muscles and fascia. We still have peritoneum, and we have abdominal contents. Now our instruments are basically set for the area of anatomy. In this case, the anatomy being relevant anatomy for a C-section. Okay? So let's talk about that. Relevant anatomy. Okay? Give me some relevant anatomy for a C-section. Raise your hand if you guys know. Yes. The uterus. Okay, that's one. That's the most relevant, right? Yeah. Of course, guys, look. If you understand the anatomy and physiology, you're going to understand what to have for instrumentation. You're going to understand what packs to have, what supplies, and what materials. Okay? Exploratory lap versus C-section. Are the instruments the same to get into the skin? How about to get past the skin and start dissecting down to the layers? Has anything changed yet? Grabbing the fascia. Same, right? Grabbing the fascia, what instrument? Poker, very good. Or tissue with teeth, right? This is the same as the exploratory lateral. Right. Getting down now into the peritoneum. Peritoneum, the same. The only difference is going to be the layers. There's different layers whether you go transverse, midline, or again along the sides, perimedial or perimedial. That's all going to be a little different, right? That's what I'm saying, guys. Relevant anatomy. Get that in your head. While you're doing case builds and case studies, make sure you also, somewhere in your notes, you list the relevant anatomy. Okay? So your case builds are going to change slightly when you guys go to clinicals, and you're going to want to list relevant anatomy. Why? Because now you're actually there, and now you can see what tissues and layers are going through during surgery. All right, going back again. Now, once we get into the peritoneum, past the peritoneum, into the abdominal cavity, same thing with retractors. Yes, now there's a little difference. Now we're getting into the area of relevant anatomy. Let's talk about some other anatomy that might be there during the C-section. Anything besides the uterus?
Bladder.
Raise your hand, but yes, bladder.
Oh, sorry.
Okay? I want to give everybody the chance.
Okay, sorry.
But pick on somebody that looks like they're lost. All right, so the bladder, 1 second. The bladder, why is that important? Are we doing any surgery on the bladder? But is the bladder there? Yes, you guys know the anatomy. The bladder is right around, again, that Mons pubis area. Do we need to get it out the way? Yes. Okay. Instrumentation-wise, do we have instrumentation necessary to get the bladder out the way with the exploratory lap setup or laparotomy or a major tray in this sense?
Get out of the way.
Kind of, sort of, right? Get it out the way with the retractor. We have retractors that can do that. Now comes the specialty of the C-section. The C-section tray will have a special bladder retractor. You guys kind of have one here. Anybody know what retractor that might be? Again, the word is special retractor for it. Now, the answer not might be in this setup, but the answer is definitely in a major setup. The wing nut is only holding on to the retractor, right? You're close. The Balfour is the whole set. Okay? Why would we not use a self-retaining retractor?
Because then I did too much more with that. Actually, I know too much pressure on it.
There's a baby.
Yeah.
And you have to bring it through metal. Right? Metal's not going to stretch. Metal's not going to bend. Okay, so we need a lot of handheld during the C-section. If anything, if you guys saw the video, they use an Alexis retractor, which is an disposable rubber type stretcher retractor. Okay? Really rare for them to use that, but it can be used because it stretches. You're not going to pull the baby out and there goes the shoulder on a metal piece, right, or the ear or foot or something. So we're not going to use the Balfour, but we're going to use something from it. Anybody have an idea? The bladder blade. What are we doing again? We just talked about the anatomy. And now we know that there's a bladder blade to the Balfour, right? Yeah, so can you use the bladder blade that's here for the retraction of the bladder. Yes. There's also a Feely bladder blade that's made for a C-section that has similarities to the bladder blade, but it has a big U bend in it compared to a simple little oval bend like your bladder blade on the golf one. Why is it shaped that way? Because so is cephalad, your head. So when the baby comes out, there's that nice U-shaped bladder blade that you can use to get the baby out. Okay? And that will be handheld. More than likely, you, the surgical tech, are going to hold that instrument. Definitely. All right, and other things, again, simple retractors and instruments that you might not have here. Again, will you have on O'Sullivan, O'Connor here? The answer is no. Again, that's one size. Again, the baby can be many sizes, and we can't. Okay, let's try it. Let's try to fit the baby through this. No, right? Not enough lube is going to go ahead and help it. So that is a GYN instrument. Okay? Remember, we're doing OB. So this specialty is OB, obstetrics, being the C-section. Okay? This is why I wanted to specialize this for you guys. So you have a better understanding. Other things that you might have are 2 suctions. With a C-section, guys, you usually have 3 doctors in the room. You have your surgeon, you have an assistant, and then you have a pediatric doctor. Okay? Pediatric doctor, not surgeon. So they usually don't scrub in. Okay? All they do is take care of the, again, infant, right? The preborn, the little baby, the thing that just came out. Okay? That doctor is taking care of that. Okay? So you guys got to make sure and understand that your hands are going to be very busy, even though there's going to be 2 people retracting and helping. This is a fast-paced surgery. So get to know how to get into the body as fast as you can, because now you guys need to be above that, right? Again, the setup was slow to begin with. Now you got to understand that the steps are going to be faster because the baby is in need. The baby needs to come out. The mother also needs to make sure they deliver the baby without any distress to either the mother or the baby. So you guys got to be on point. All right. Any other anatomy that might be there? Now, fallopian tubes and ovaries are usually not part of the C-section, right? But they're there. Okay? Why is it important? Sometimes you might need to do a tubal ligation along with the C-section. Some doctors that they have access and the patient has given permission, they'll go ahead and do a tubal ligation. Tubal ligation is as easy as clapping the fallopian tubes, cutting them, and ligating them. Many different techniques that you guys have read. We can use clips, we can use sutures, we can use electric cautery, and we can use anything as up into harmonic scalpel, plasma kinetic, blah, blah, blah. Get to know your surgeon, you guys will know the differences between the sites. Okay? All right, now, is there bowel there also? Definitely. Again, with the C-section, we're not going to be doing a Trendelenburg or reverse Trendelenburg. More than likely, your patient might be awake. Remember, there's 2 types. We can do epidural or spinal. You guys know the difference between the 2? Really quick. Epidural, the injection is given around the dural space. They usually numb sensory nerves. Feel that? Sensory nerves. A spinal usually goes in a little deeper and numbs all nerves. What's the difference? During epidural, you can still move. We want you to move. We want you to expand. We want the uterus to contract and try to push the baby out as we're taking it out. Okay. When it's spinal, when we don't want any movement at all, we don't want you to kick, we don't want you to do that. We don't want you to have no pain either because we got big old incision made too. So it all depends on your patient. Also what we're going to do. Okay. So how is that important? Why is it important knowing that there's an epidural versus a spinal? A good test that we do when we start surgery is to check if the patient still has sensation, feeling. Okay? Do you feel this? Yes. Do you feel this? Yes. Do you feel this? Yes. No, we didn't even touch it. Sometimes it's psychological too. But yeah, literally we go there and test to see if you can actually feel. What instrument do you think you could use here to start feeling? Yes.
Alice?
An Alice? That's kind of aggressive.
Babcock?
Okay, Babcock's kind of aggressive. We haven't even started surgery, guys. We're just checking to see if the patient feels it. Oh.
With no blame.
Smack it.